In the meantime, I ask my co-chair, Professor Rimmelé from France, to present the application of adsorption in acute disease and critical illness. The paper presented by Vincenzo opens new hope and interesting options for the future. And I think that this is something we really need to further explore, creating some more evidence and more information. Now we will see about the acute patients.
Thank you very much, Claudio. So thank you very much to Jafron for organizing this symposium. Thank you very much for inviting me. So during the next 15 minutes, I'm going to talk about hemoadsorption in sepsis, in septic, critically ill patients. These are my conflicts of interest. I work with different companies in this field, including Jafron. This is the outline I'm going to follow in the next few minutes. I'm going to come back on general considerations about the host inflammatory response in sepsis. Then I'm going to review with you the literature on what's available in sepsis with the Jafron technology. And then I'm going to finish with a few questions that I think we should be focusing on during the next years. So what is this host inflammatory response in sepsis? First, 2 slides on epidemiology, because I think they are very important. I've been working in the ICU for 20 years, and I always heard that sepsis is the primary cause of deaths in the ICU. No debate about this. But recently, like from data released 2 years ago, we know now that sepsis is not only the primary cause of death in the ICU, but it's also the primary cause of death in the hospital. In all hospitals, outside the ICU, sepsis is the primary cause of death. This is data from the US, from 5 large academic centers. And they looked at all the causes of death in all the patients who died at this time, during this period. And sepsis, as you can see here, was by far the primary cause of death in the hospital. Another study that I really enjoyed to read, it's this one, published in The Lancet 2 years ago. It's global mortality about sepsis. And if you look here, we learn that if you look at all the causes of death on the planet every year, we learn that 50 million people die every year on the planet from all causes. 50 million, it's also the number of sepsis, cases of sepsis worldwide every year. And we know that 11 million people died of this condition every year. So sepsis represents 1 in 5 deaths worldwide. And in the past, we thought it was by far less. So this is twice as many as previously estimated. I think this is very important to acknowledge this new epidemiologic data. Another important thing about this host inflammatory response is what was said by Sir William Osler already 100 years ago. He said that except on few occasions, the patient appears to die from the body's response of sepsis rather than from the infection itself. 14 years ago, the pathophysiology of this inflammatory response was well described by Richard Hotchkiss. And what did he say? He said that this inflammatory response, you have 2 inflammatory components, the pro-inflammatory components and the anti-inflammatory components. Both components occur at the same time, but the net balance is more on the pro-inflammatory side during the first hours of the sepsis time course. And then after a few hours, the net balance is on the anti-inflammatory side. All of this is due to the release of all these inflammatory mediators, these cytokines. And this is very important to remember that now we know that this immunosuppression state is extremely deleterious for the patient, because at that moment in the ICU, the patient cannot fight against nosocomial infections, cannot fight against viral reactivations, and that's why 80% of the people who die from septic shock, they die because of this immunosuppression. Okay? This is very important to now understand this. Immunology is now part of our daily life in the ICU. Every day we now are going to get results from the immunology department to better understand how these septic patients deal with these organ dysfunctions. And you know, it is even in the definition of the sepsis. Like 7 years ago now, published in JAMA, the new definition of sepsis, sepsis should be defined as a life-threatening organ dysfunction caused by a dysregulated host response to the infection. So the host response is now part of the sepsis definition. That's very important. When we manage sepsis patients in the ICU, we pay attention to 3 very important things. Of course, the antibiotherapy, as early as possible and as well adapted as possible. The source control is, of course, very important. If the patient needs to go back to the operating room to get operated, for a peritonitis, for example, he has to go to the operating room as quick as possible. And of course, this is our daily job in the ICU. We deal with organ support, right? If the patient has hemodynamic impairment, we deal with fluids and with norepinephrine. If the patient has respiratory failure, we need to intubate the patient. If the patient has kidney dysfunction, of course, we need to provide renal replacement therapy. But still, if we do this very correctly, the 3 things very correctly, the mortality rate is still more than 40%. So that's why we need to find, in the upcoming years, some adjuvant therapies if we want to decrease this mortality rate. And at this time, immunostimulation, like in the cancer field, immunostimulation is under evaluation with IL-7, with GM-CSF, interferon gamma. But also, what I'm going to talk now is all this field of extracorporeal blood purification techniques that you can see here with one of the Jafron cartridge. These extracorporeal blood purification therapies are under evaluation in sepsis. This is also something I'm reporting here. You know, this is sepsis-induced acute kidney injury. The pathophysiology is very complex. We don't really know how these circuits, you know, this is like a CVVH circuit or a CVVH, this is a CVVHD circuit. And if you place here a membrane with, of course, some specific properties able to provide some blood purification properties, but also these hemoadsorption cartridges, we don't really know how they are going to interact with this pathophysiology of sepsis-induced acute kidney injury. There are some possible mechanisms that we need to better understand, and we need to understand if this is good to remove endotoxins, because you know, the endotoxins are the trigger of the inflammatory response. Claudio, 20 years ago, this is kind of an anniversary, right, Claudio? 20 years ago, you published this peak concentration hypothesis that with these techniques, we can decrease the peaks of these cytokines. The peaks of cytokines can be decreased by these therapies. With Professor Kellum in the US, we developed the chemokine concentration gradient hypothesis, which is that, you know, between the tissue, like let's say this is an infected lung here, a pneumonia, and you have here the blood circulation, then there is a gradient of cytokines, a gradient of chemokines, and we know for sure that this gradient is extremely important to drive, for the leukocyte trafficking, to drive the white blood cells to the site of the infection. And by applying a blood purification device here, you can modulate this gradient, and maybe this is why you can drive the PMNs to the site of the infection and improve outcome. That's also a hypothesis. Another hypothesis which needs to be validated is the adsorption of not cytokines, not endotoxins, but the cells by themselves. The white blood cells can be adsorbed on the divinyl benzene beads. Okay, so maybe there is an interaction between the sorbent and the leukocytes, leading to the modification of the expression of some leukocyte surface markers like HLA-DR. And I think this is very important because HLA-DR, as you may know, is a great marker of this immunosuppression state. Now here, we are not immunosuppressed, I hope, and we have an expression of monocyte HLA-DR of 15,000, of 20,000 antibodies per cells. But in the ICU, when the patient is with sepsis-induced immunosuppression, the level is very low, it's 5,000 antibodies per cell, showing that there is this immunosuppression state. So we need to work on all these hypotheses. In 2023, we have all these techniques available. We have the sorbents, so you run the blood through the sorbent, so the cartridge. You have polymyxin B hemoperfusion. You have other companies providing some devices, and we have the cartridges from the Jafron, HA330, and now for sepsis, we have this HA380, which has been released recently. The CRT filters, the random CRT filters, they also can provide some specific properties, providing an addition blood purification property. The Oxyris filter that you may know, the high cutoff membranes, they not only provide kidney support, but they also provide blood purification by the removal of inflammatory mediators. We have new blood purification techniques from the last 5 years. The Seraph, for example, from the Xtera company, the Seraph, this technique is able to remove from the blood bacterial components. And then we have also circuits from the US that are also very interesting. In the past, we used high-volume hemofiltration, cascade hemofiltration, pulse high-volume hemofiltration to remove these cytokines. Plasmide changes also can be proposed for blood purification and CPFA. So now, what's the literature about hemoadsorption with the Jafron cartridges? Well, I think the most important publications are the ones I'm going to show now. This is a Chinese study comparing two groups of 15 patients. One group receives CVH in the renal dose, 35 ml per kilo per hour of CVH. And then the patients were compared to pulse high-volume hemofiltration. So they received 6 hours of 85 ml per kilo per hour, in addition to, during the rest of the day, it was normal CVVH, plus hemoadsorption with the Jafron technology. And if you look at the cytokine levels after 24 hours, but even after 2 hours, IL-6, IL-10, and TNF-alpha, the concentration was decreased in the group of patients who received the combination of pulse high-volume hemofiltration and hemoadsorption. This is a study from our friend from Bangkok, from Professor Srizawat. He took COVID patients, and he took the most severe COVID patients. He did not take the non-severe patients, like they have been excluded from the study. And then he ran hemoadsorption with the Jafron technology in these patients. In 15 patients, they received just 1 or 2 sessions, and in 15 other patients, they received more than 3 sessions. Look at the mortality rate in these patients. The ones who received more than 3 sessions of hemoadsorption all of them almost survived. And the ones who did not, unfortunately, died. I don't like to show in meetings case reports, but this one, I couldn't help myself. I wanted to show you this case report from Turkey. This is a 42-year-old patient. This patient got a symmetrical peripheral gangrene in the feet and the hands after hematopoietic stem cell transplantation. Look at the feet and the hands of these patients. Sometimes we get these patients in the ICU, and when we see these feet and the hands, usually, almost all of the cases, I've never seen that there is no amputation of the fingers. These patients received 3 sessions during 3 days of hemoadsorption with the cartridge HA330. The blood flow was 200 ml per minute, and 1 session lasted 150 minutes. No amputation was performed. All of them, I mean, the feet and the hands got much better after the sessions. This is another study from, it's an observational study from Turkey, and the table here comparing the survivors and the non-survivors. It's 11 patients who received also hemoperfusion with the cartridge from Jafron. Actually, it's not so important to compare survivors versus non-survivors because they're not so different. The patients were very severe. The mortality rate was 60%. What was interesting in this study is that they selected among all their patients the ones who could benefit from hemoadsorption. And they took the ones who were the sickest, right? Use of high-dose vasopressors in the ICU, dysfunctions of more than 2 organs. So I think it's very important to this technology is probably not for all septic patients, of course. We have to select the sickest one. I think the selection of these patients is key. For the next few years, this is what I think we should focus for the research. Sometimes in congresses like this one, especially in the intensive care field, we hear that, blood purification doesn't work. We have large randomized controlled trials that are negative, so blood purification just does not work. We hear this, and I'm sorry, but I strongly disagree when I hear this for several reasons. First, because they are telling you that all studies are negative. This is totally untrue. This is a randomized controlled trial. This is a meta-analysis from Professor Kellum in the US. He took all the hemoadsorption studies and reported a signal in favor of hemoadsorption. Claudio, you know this study, right? Published in JAMA, 2009. Positive trial. Okay, this is a positive trial with polymyxin B hemoperfusion. So it's untrue to say that all data is negative. This is another one. It's very interesting because this is a Euphrates trial, polymyxin B hemoperfusion in septic patients. The whole study is negative, but when you look again at a specific subpopulation of patients, then the signal becomes positive. So that's interesting also. And then all these studies negative, they are here. The IVOIR study with high volume hemofiltration, Abdomic study with polymyxin B hemoperfusion, Compact one with CPFA, they are negative, true. But they are full of limits. And when a study is negative, it's interesting to see that people, they don't talk about the limits. When a study is positive, yes, let's look at the limits. But when a study is negative, nobody is talking about the negative. Nobody is talking about the limits of the study. Then if you don't believe this data, if you don't believe if blood purification is good or not, if you don't believe Claudio, if you don't believe me, then just ask the sepsis experts, which we are not, right? Let's ask these guys, what do they think about blood purification? They are telling us that the evidence is too low in favor or against the blood purification techniques. So additional research should be done. And this is what we keep saying with Claudio and many other people, the ADKI group, more research is needed in this field. Why these studies are negative? For sure, because of this reason, in these sepsis trials, they took all the patients in the ICU who were septic. The gram-negative sepsis, the coccigram-positive sepsis, the sepsis from the urinary tract, the pneumonia, everything together. When you do this, you can do everything, but it's going to be negative because you are not going to see the positive effect on the subpopulation of patients. This is very important to understand. And be careful also because all these companies, they provide new devices years after years. And the gap between the technological progress and the medical knowledge of the pathophysiology is increasing, I think. So basically, we don't know how to use these therapies. We don't know which patients exactly, how to select the right population. When do we need to implement these techniques? Which timing? We don't really know. And what to remove. I told you at the beginning that there are many things we can remove. Now we can even remove the bacteria, the viruses. Everything can be removed with all these technologies. But we don't know which one is best to remove. So in conclusion, my take-home message is, first, 2023, immunology is part of the sepsis definition. It's part of our daily clinical practice in the ICU. The patients that die of septic shock because of sepsis-induced immunosuppression, will these techniques, blood perfusion techniques, be one day part of the sepsis management? I don't know, but blood perfusion techniques, such as hemoadsorption, are currently under investigation, and we need to do this seriously. These multi-center trials were negative. Were they well designed? That's the question. We have many unanswered questions that needs to be answered. How do they work? Which patients exactly? When exactly? Which timing? What to remove? Cytokines, endotoxins, leukocytes, bacteria, viruses. So I hope I was able to convince you that research in this field should definitely continue. Thank you very much.